we're good with the time. So.
Now we have the panel. I hope that the panel participants are here. Are we able to check that? We have Sanjin Musa at least here in person. Please, would you like to come to the stage? And then virtually we should have Sif Nielsen from WHO. I hope. Are you able to see if she's here? And John Kinsman from ECDC.
I am here.
Hi, Sif. Welcome. Can you hear us?
I can hear you clearly, and I can see you as well.
Great. Thanks a lot. And then John, are you here?
I am here. Can you see me and hear me?
Yeah, we can. Great.
Okay. And I should apologize. I've got the wrong background, but that's from a previous meeting. Sorry about that.
No worries. We see your message clearly. And then we should have George Panagiotakopoulos from Greece.
Hello from Athens.
Hello, welcome. I think we're all set, or according to my list, Karam wasn't able to join this panel as planned, unfortunately. So in the same way as we did the presentation, we thought that we would split this discussion into two parts. First, looking at maybe the more general questions relating to vaccine hesitancy work and the topic in general, and then from there move on to the social media part. Just a question to the virtual panelists: are you able to see the screen with the questions?
So I don't see any questions.
You don't see the presentation?
No, I see a blue screen, but no words on it. But maybe it's just my screen. Let's see if
me
the
too.
others.
I don't see it either.
Okay.
Are you able, John, to see anything?
No, I see you and
You see
someone
me.
sitting down and then me. That's
Are
it.
we able to do something technical about this, maybe? To see the presentation, to show the presentation to the panelists.
Okay.
That would be
There we
great.
go.
Yeah, I can see it now.
Yeah.
Oh, great.
No,
Wonderful. Thank you
There we
so
go.
much.
Mhm.
Great. So we will not go through all the questions in specific, but looking at the three first questions, what do you think should be the focus areas of vaccine hesitancy and uptake work in the future? How could we better coordinate and capitalize on the existing work? And how could we better prioritize vaccine hesitancy and uptake work? Thinking about these three questions in the beginning, it would be interesting to hear your thoughts and your comments on these. I was thinking maybe we could start with Sanjin, as you are here in person, and then move on to Sif, and then John,
Okay.
and then to George.
If I just can give one suggestion, maybe you can join also here, you know? So,
Sure.
Yeah,
Yeah.
let's make also
Absolutely.
here more. People who are in person here, so yeah. So thank you, Jonas. So I was thinking really at the end now we have vaccine hesitancy, but of course everything is interconnected, you know. So whole today conversation that we have, you know, discussions that we have could be linked with also with vaccine hesitancy. Today someone mentioned also that you have also supply issue regarding that. For me, from my perspective, someone who is coming is from LMIC. That is also important factor, you know. So also one, I would say, I would like to underline important question and findings from, I do not recall which package is that, but with vaccine shortages. I was so surprised when I saw that results. I also give my answers for that, you know, and that so many countries in EU are experiencing vaccine shortages, you know. So, but that's not the end of the world, you know. So it's temporary shortages, you know. You have to recall system. That is also one of the key factors for vaccine hesitancy. It's important, but so that also it obviously in some countries can be one issue. Regarding the vaccine hesitancy in Bosnia and Herzegovina in Federation, we did a lot in the recent years. Mainly because we implemented the TIP project supported by WHO. So we started that 3 or 4 years ago, or 2 years before the pandemic, and we really acquired a lot of knowledge regarding all these insights regarding the barriers and drivers for vaccination. So we started with work with healthcare workers, then with the parents who refuse vaccination. So based on that, this final tip report you can find on WHO Euro website. So it's really published like 2-3 weeks ago with fully how we implemented it, designed it. And at the end, we have created interventions. So 2 interventions before pandemic we implemented. Unfortunately, we have ideas for further one, but 2, I would say, which are, I would underline as maybe even the most important, are related to communication of healthcare workers. So yeah, so all that paradigm and communication between parents and healthcare workers, this is also from our findings from qualitative study, raised that issue that, yeah, now it's difficult and the parents challenge now physicians regarding some questions connected with vaccines. So they have to be knowledge, to raise the knowledge also, but also some things that we implemented by support with UNICEF. One program, I think Hill is also a colleague from Serbia, that they also implemented it. It's so-called interpersonal communication on immunization. It's one program developed by Johns Hopkins University, and we implemented that in Bosnia and Serbia. And I was also a member of UNICEF team who implemented that in the Icaro region. So this is also something new. I would say that is important. That for vaccines, it's not just that you have to provide information, So you have also to use empathy and other non-verbal, verbal techniques, how to convince someone, that is important. So vaccine hesitancy issue is really important. That also show us pandemic. So the first challenge was how to develop safe and effective vaccines, and that was excellent job. Then how to produce and distribute vaccines. I would say that was far from excellent, right? From my perspective of my country, and other countries, LMICs. And the third one, how to convince people to get vaccinated. That also, some countries did do good job, some countries didn't do good job. Also, all during pandemic, we also, by support of WHO, we implemented one behavioral research, and one of the questions was regarding to vaccination, and that will be very soon published in International Journal of Public Health. And for me as a researcher, that was really interesting we ask about vaccine intentions for vaccine that are in developing process. So that's also interesting. Thank you.
Thanks a lot, Sanjin. Just to check, Sif and John and George, can you hear me when I speak to this microphone?
Yes, we can.
Great. Sif, would you like to take it from here? It would be great to hear your comments and thoughts.
Yes, I can do that. Okay, thank you so much. And thank you so much for the invite, and good afternoon, everyone. So I think what I would like to share in regard to the vaccine hesitancy is that somehow I think the last year dealing with COVID-19 uptake in various countries in the European region, I think that's a good example of somehow we should try to be a bit more nuanced when we talk about vaccine hesitancy. And what do I mean about that? I think somehow we should try to talk about vaccination readiness, because when we say vaccine hesitancy, we indicate that people are not keen on getting the vaccine. And the studies that we have done in more than 10 countries over the last year on COVID-19 vaccination actually show something different. So, and it shows a more nuanced photo and a picture of it, and also a more, as mentioned in the presentation, a more holistic approach to it. So actually what we have seen is that not necessarily are people hesitant to get the vaccine. There could be structural barriers, and even more important, actually often programmatic errors or issues. And what do I mean about that? So that's really trying to look at the entire national immunization program. And that's what I meant about the holistic approach. Because often when we talk about vaccine hesitancy, we somehow put the blame on the population. So it's easier to say that, it's the reason that we do not see a higher uptake is due to vaccine hesitancy. people, they don't want to get it. It's misinformation circulating on social media. And we then put the responsibility on a population level, and we forget about what else can be done from a more programmatic level, but also politically. It has a great influence. And for instance, with the COVID-19 vaccine, we have seen results where, people are keen on getting, any other vaccinations, but the COVID vaccine were the one that they have been a bit hesitant in getting. And that actually shows that it's nothing to do necessarily with the vaccine. So it's not the vaccine that they're against. There could be any other issues, the way it's been communicated about in the country, the fact that the government might not be visually supportive of the COVID-19 vaccine as well. That could be, communicating about the COVID-19 vaccine from various stakeholders, not being aligned, not having one message. And of course, also the fact that there's, a lot of negative influence from social media. So it's not that I want to disregard that for sure. However, our result had actually shown, so we have worked with more than 10 countries to conduct qualitative research to understand the barriers and drivers for COVID-19 vaccines among specific target groups. And based on that insight, we have supported countries with conducted tailored interventions. So we have tried to look at anything that can have an influence on the willingness to get the COVID-19 vaccine, of course, personal knowledge, social factors, but also programmatic issues. As also mentioned, that could be the convenience factor, that could be, lack of stock supply, not feeling comfortable to go to the healthcare facility, and so on. So really also look at the programmatic issue. And actually, when we look at the recommendation that we gave to the countries of interventions, like more than half, or 50%, in some cases, even more than that, has to do with the actual, structural programmatic issues. So not necessarily, trying to tackle misinformation on social media or big communication campaigns that are targeting the general population, but actually much more narrow on either really deep in on community engagement and or programmatic issues. So I think it's important when moving forward, trying to maybe approach the vaccine hesitancy a bit differently, maybe talk about it as vaccination hesitancy or readiness. So we also somehow try to, have a positive discourse around this, because people that are actually keen on getting the vaccine, but the more that we try to emphasize the vaccine hesitant part, somehow there's a bit of a negative and a bit of resistance to it. I hope that makes sense. And then, of course, moving forward, working together, how can we coordinate, align? I also think that each of us should be better at, documenting what we have learned. The information that's already out there, it's actually a bit limited in regards to which interventions is actually working. We have an idea of now the barriers and the drivers, but when talking about implementation, action, what works, it's actually quite limited what's out there. We know at the broad sense, education, training, but again, it's super context specific. And it would be great to have a bit more documentation of what is actually meant by training. What kind of training, the content of training, what is the trigger part? When we talk about communication or community engagement, what's actually meant by that? So a bit more specific, concrete example. I think that would be great to be able to share, among other countries, because I think that gives a bit more concrete, a deep understanding, insights into what can actually be done to make a behavior change among different tailored target groups. I think that was it from my end, and I'm happy to elaborate. Over.
Thanks a lot, Sif. I couldn't agree more with what you just said. Many things that are really topical and important. John, would you like to continue?
I would, and I would also just like to say that what Sif has just said is to some extent exactly what I was going to say, specifically referring to the concept of vaccine hesitancy, which I think is a somewhat overused and often ill-defined term. and with it comes a lot of values. I think it's very easy to judge people for being so-called vaccine hesitant. And in fact, what they really are is unable to get someone to take care of their kids so they can actually get to the place to be vaccinated. And it's a structural issue. And essentially, if I may say so, it's actually a failure of the state to provide a service, an essential service for the people on the terms and an acceptable way for them. So I think and this is something at ECDC that we're really trying to move away from, is to not use the term vaccine hesitant. Not that vaccine hesitancy doesn't exist, because it does, but because the term is often ill-used, and I think therefore it's a risky term to use. We tend to talk about vaccine acceptance, exactly as Sif says, spinning it in the other direction, trying to see it in another light, so that the normative behavior is to accept, rather than the implicit behavior that is normative to be hesitant. So that's one thing, and very much to endorse what you've said there, Sif. I'm aware of time, so I'm going to be very brief. Two other things I want to say. There's much more I would like to say, but there's very shortage of time. One of the challenges I think we have in this field is something of an overabundance of models and frameworks, and we don't really have an approach to using these. And somebody mentioned earlier the 5 C's, which I personally agree. I think it's a really useful, very simple model to use. You could also talk about the 3 C's, the 5 A's, the BESD model, and all these different things. But I think the fact that we've got these different models essentially saying the same thing in different packaging is problematic. And I think moving forward, it'd be really helpful if we could have a discussion about how we could somehow consolidate this sort of plethora of different models into something which would be a bit more easy to grasp for people. Final point about prioritization. It's amazing to me how 6 weeks ago, everything was all about Omicron. Everything was all about, we desperately need to get people vaccinated. This is the issue. In the current climate, vaccination has completely fallen off the political prioritization. And this is very problematic because obviously COVID hasn't gone away. We're also very potentially facing a serious upsurge in measles cases anytime soon. We can expect that to come because of under-vaccination of kids during the pandemic. So we have to be very, very careful about how we prioritize this. We need to strike while the iron is hot whenever the opportunity comes. And so just finally, just to say, if we are unlucky enough to have an upsurge in vaccine preventable diseases such as measles in the coming weeks and or months, let's take the opportunity as a physician, hopefully who can be listened to whisper carefully in the ears of the decision makers. Let's now focus again on vaccination. Let's not lose this train that we've been on so effectively with COVID. So when there's an opportunity, we must strike, and we mustn't let our attention be completely absorbed by other horrible things that are going on in the world. So let's just keep the opportunity going for whenever it comes. Thanks very much. I must stop there, otherwise our other colleague won't have a chance to have his word. Over.
Thanks a lot, John. I really appreciate it. George, are you still here with us?
I'm with you, still here.
Great, thank you. It would be really, really great to hear your thoughts about all this. Please go ahead.
Good afternoon from Athens, Greece. Thank you so much for participating in this very interesting meeting. I really enjoyed the presentations. They were very to the point, and they contained a lot of information. I more or less agree with the previous panelists, so I will be very, very short in my intervention, just a couple of points. Let's discriminate hesitancy from anti-vaccinationism. It's a different term, I would say. It's milder. Hesitancy is debatable somehow. It's concern. We have concerns. Concerns about what? I should like to split in two: concerns and hesitancy about efficacy, concerns and hesitancy about safety of vaccines, because it's not the same. As far as safety is concerned, I would like to stress out the pharmacovigilance field. We have pharmacovigilance in every country. We have committees, we have panels, we have organizations which are dealing with the pharmacovigilance of vaccines. So we need information from them. We need to have their data simplified, of course, and illustrated, but in a way given to the layman, so that the general public, the lay people, can be convinced, can understand that we are here to protect them. I mean, to protect them with the vaccines, that there is concern in us as well about the vaccines. So I think that if we speak the truth, of course, in an illustrated and simplified way to the general public and persuade them, we have more chances with hesitancy. This is in terms with regard to safety. With regard to efficacy, again, we need to speak the truth and have lists and have tables and have data given to the public. How many lives were saved? Out of how many? What happened with the X vaccine? Smallpox was eradicated. Let's create a story about that. And since I'm referring to stories, I also believe that we need narratives and we need heroes as well. I will give you an example. Maurice Hilleman was the cardinal vaccinologist of the 20th century. He constructed, I think, 14 out of the 20-something vaccines that we are using today. 14 vaccines were invented and devised by Maurice Hilleman. When he died in 2005, the Time magazine had him as a cover story. And under his figure, it was this phrase, Maurice Hilleman, the unsung vaccinologist, the unsung. Nobody knew him. We don't know him now either. And he was a hero of the 20th century. We don't have a movie on his life. We don't have a story. Not only Maurice Hilleman, this is an example. Jonas Salk, for example, or Alfred Sapir, or even Edward Jenner in the 18th century, who was the pioneer of vaccines. We don't have narrations and stories and movies about them. If we had, this could infiltrate society and transfer the meaning of vaccination that some serious people, some important people performed and gave those things, those presents to humanity that saved so many lives. I'm strongly fond of these stories, and I believe that from a communication point of view, since we are talking about communication now, we need heroes and we need narratives. Thank you so much.
Thanks a lot, George. I couldn't agree more. That was a good narrative too, I think, from your side. Unfortunately, I think we are going over time a bit. We have time. Are you sure? Because we still have some points on the social media part. So if you have the possibility, if the panelists still can stay with us for 5 or 10 minutes, it would be great. If not, we completely understand it. And thank you a lot already for your input. But if we have the time, Olivier, we would be very happy to continue with the social media part. Francesco, I will give it to you.
Yeah, that would be great if the panelists, in fact, still have time to stay with us. We had proposed a couple of questions also on social media. One was on the idea of having a European coordination of social media monitoring, which could be, for example, for suggesting a methodology, a robust methodology to set up social media monitoring activities in different countries. And also, if any one of you has suggestions or experiences to say, probably maybe John Kinsman can give a contribution on that, on how to use data from social media monitoring to develop specific communication initiatives.
Okay,
here.
Thank you.
Yeah.
I'll just give you just briefly a comment. So I think it's really important. You presented us also today, and I congratulate you on your work, especially because today during the lunch we were speaking about our new studies regarding the immune response, and you have time also to do social network monitoring. But that is the beauty of vaccinology. It's not just infectious disease, microbiology. That is also social sciences and how people react on vaccines. So I think that's really important, especially about these nuance, I would say. So when we say hesitant, yeah, so yeah, I also agree. We shouldn't blame someone, you know, because being hesitant, but we should distinguish here that they are not anti-vaxxers. We don't think that they are, you know, so those who are hesitant, they are victim of propaganda. They do not spread propaganda, you know, so anti-vax propaganda. So yeah, they are affected, and if you are monitoring, you will see that those comments, those misinformation, etc. You know? So I think one organized approach how to monitor it should be really important. Also, something from our region who share the same or almost the same language, that could also be important. We are releasing the same media, etc. And I found, I read some analysis in a region of Southeast Europe, and yeah, really important monitoring. So, and your work is contributing to that a lot. Thanks.
Thank you very much. Any other comment from the other panelists?
Well, you specified my name, so I can try something here.
Yeah.
It's interesting you ask about the examples of social media monitoring. I mean, from an ECDC point of view, we don't do that. And there is monitoring going on in the Commission, and that they produce quite regular updates on different things that are going on. And I think probably WHO also does similar sorts of work. But I do want to give one example of a good practice, and I hope and believe it's okay to do this, which is RIVM in the Netherlands, which has a very, very good dedicated team of people working on social media monitoring. And this isn't only to do with vaccination, it's to do with many different health issues. And I'm not going to step too far into it because I'm not with RIVM and I don't want to be speaking on their behalf. But I do know that they have a dedicated team, as I say. They keep a pretty close eye on many different things. And one of the misinformation issues and things that are coming up, and I can share one thing which we have published about, so it's in the open and it should be okay to say this. This relates to Lyme disease. We did a project a few years ago on community engagement with Lyme disease, and RIVM has, of course, as many countries, there are problems where there is Lyme disease, people who have chronic sequelae from the initial infection. And this has been quite problematic in various respects. So RIVM have been engaged previously, at least, with some of the people who have been opposed to different positions and so on. And they've actually reached out to individuals on an individual basis. They've identified people online who have been saying things that maybe aren't in line with current scientific thinking, let's just say. And what's really interesting is that these people haven't been doing this to disseminate disinformation. In other words, they've not been doing it to confuse. They've been doing it because they believe this was the right thing. And by reaching out to them and by listening, I think that's the key. It's the dialogue. The social media monitoring listens to what's out there, but then the recipients in the RIVM have been listening to the people, and they have been then speaking with and dialoguing. What's going on? Why are you thinking this? And there have been cases where they've actually then been able to work with people who have then become ambassadors for a different approach, let's say. So by using the social media monitoring to identify people who may be inadvertently putting out information which isn't correct, and actually working with those on an individual basis, it's possible to do quite good things. So in terms of numbers and so on, I can't give you any details, but I do know this has happened, and I think it's been quite an effective way. So obviously labor intensive, it takes work, it takes investment and resources, but it can be done.
Very much. Thanks, John. Yeah, I think it's very interesting also to collect, probably maybe a research line for the future, to collect best practices on the way you can apply social media monitoring data. This is something that could make them very actionable and give good examples to different member states. Is there any other comments from the panelists? I think we're quite done with time.
Maybe if you have Sif or George, do you have any comments still on the social media part?
Okay, maybe
or maybe
we can close the session.
Maybe you have left. Anyway, thanks a lot to all the panelists. It's clearly a topic that people have a lot to say about, which I'm very happy about personally. It has been a really good and fruitful conversation together with you. So we appreciate it a lot, your participation in this. And I think we're done with this part of the presentation. So thank you.
Thanks, everybody. Thank you very much.